everyone. I am Dr. Keval. I am Associate Professor in the Department of Cardiology at UNMICRC Institute of Cardiology and Research Center, Ahmedabad. I'll be discussing a very relevant topic today, that's vascular closure techniques. Now, if you look back more than a decade back, then we would be wondering why is the need of a vascular closure device or something like that required. But since the advent of more and more structural cardiac interventions, particularly transcatheter aortic valve implantation, mitral clips, vascular closure is becoming a very important topic. It has not only its role in large bore closures, but can also be used for closure of routine access like a 6 French or a 7 French vascular access. Excess site complications are one of the important events which are related to the morbidity as well as in some cases procedure related mortality. It's most commonly seen with large vascular excesses, and closure of the excess site has traditionally been done with the use of manual compression. If we look at the data of coronary interventions, we see that the rates of major complications range from 1 to 15%. When you do an intervention from femoral axis, if you're doing a diagnostic procedure, the rates of femoral side complications are around 1 to 2%. For therapeutic procedures, they range around 4%, which is the data from large registries. The rates of bleeding vary in different studies ranging from 2 to 14%. Now, the use of vascular closure devices is predominantly for large bore vascular access. So, large bore vascular access is commonly used for structural cardiac interventions and mechanical circulatory support devices. So, IBP uses an 8 French access, Impella uses a 13 to 22 French access. Tower requires either a 14 or 14 to 20 or 22 French accesses. Mitral clip requires a 24 French venous access, and some other structural interventions like implied servo-occluder will require 8 or 9 French venous access. But most important is patients who are undergoing structural cardiac interventions like coarctation of aorta, stenting or TAVI. These are groups of patients who have large bore arterial access and they need to be managed with vascular closure devices. Now, coming to the traditional method, manual compression, which was considered the gold standard for vascular closure, the problem is it requires trained personnel in ACT of less than 280. Use of protamine for manual compression is again controversial because it can cause anaphylactic reaction, especially in diabetics. The duration of compression will depend on predominantly on the size of the vascular access and the level of anticoagulation. How do you do this? You give 10 minutes of firm pressure, around 5 minutes of less firm pressure, and then 2 minutes of light pressure. If your bleeding still continues, you need to maintain this for another 15 minutes. The risk factors for prolonged bleeding include severe atherosclerosis, aortic regurgitation, elderly, obese, females. These are groups of patients who have increased propensity for bleeding. The advantage is it's a continuously observed method and pressure can be modulated. The disadvantage is it takes a lot of time, patient discomfort, length of hospital stay increases, and also you need a dedicated person who will be removing all your vascular sheets. Why do we need vascular closure devices? Because manual compression has its own problems. It depends on the operators, it's cumbersome, requires prolonged bed rest, ambulation is a problem. After arterial intervention, the patient might be bedridden for almost 12 to 14 hours. So vascular closure devices were first introduced in late 1990s. The advantages that were proposed were it reduces the time labor, it reduces the time to hemostasis, will reduce the bleeding rates, does not depend significantly on the level of anticoagulations, and it's also required for patients who are undergoing interventions with large bore vascular access. The types of vascular closure devices are passive and active devices. Passive devices are basically manual compression and hemostatic pads. Active closure devices can be passive approximators like a collagen based or a sealant based, or active approximators which are basically suture based. So passive devices ensure hemostasis with the help of either mechanical compression or with the help of a prothrombotic material. Immediate hemostasis is not achieved. Again, prolonged bed rest is required in these cases. Whereas active closure devices will actively close your arteriotomy site and achieves immediate hemostasis and early ambulation. So coming to the first passive device, that is the manual compression devices. So manual compression devices are a substitute to manual compression. They basically do the same thing. They are applying manual compression, but it does not require some person continuously standing over there. That is why you can give prolonged compression in these cases. It reduces the operator fatigue but it significantly increases the patient discomfort. Various available devices include the Compass device, the Femostop device from Abbott, the Clamp Ease device, and the Safeguard device. If we compare that, if we compare mechanical compression device versus manual compression, we have seen that the prevalence of bleeding does not significantly differ between the two groups. One of the sub-studies has also found that these mechanical compression devices may increase the risk of bleeding and vascular complications like vascular thrombosis. So this is the Femostop device. It basically has an adjustable belt which is placed over the arterial access site. The manometer will help you to control the BP. It will be transparent, so you can actually see whether the hemostasis is achieved or not. We can see that this is a Femostop device. In diagnostic cases, you need to apply it for 30 minutes. For interventional cases, you will need it for around 1 hour. Then we have the Clamp Ease device, pretty much similar to what we do with a manual compression. There is a plate which is placed under the patient. C-arm will be directly above the patient. Then it applies pressure, and once the hemostasis is achieved, you can gradually reduce your pressure and remove the closure device. Right? Mechanical clamp compression versus hand pressure has been studied with the primary endpoint of ultrasound-defined vascular complications. We have seen that mechanical hemostasis may reduce the primary endpoint of vascular complications and also reduces the operator burden. Again, the data is not very strong to support the use of a mechanical compression device, and that is why it has never been used very routinely. Most of the times we go on to use manual compression in routine cases where we are using just a 6 or 7 French arterial access. Procoagulant hemostatic pads, basically they are coated with procoagulant material. They are used in conjunction with manual compression, and they will quickly achieve hemostasis. The examples are Chitosil from Abbott, and the closure pad, Syvec patch, T-Stat dry, Neptune PAD, Quick Clot, V+ pad. Basically the mechanism is that the pad will have some form of a procoagulant material, and that is why the hemostasis will be quicker. How to use this? Proximal pressure is held above the puncture site, sheath is removed, you place the pad over the puncture site, proximal pressure is slowly released, small amount of blood has to be allowed to flow so that it comes in contact with the pad, and then you give constant pressure for around 10 minutes depending on the sheath size and the ACT. Pressure is then slowly released, hemostasis is confirmed, you apply a sterile dressing and leave it in place for 24 hours. So we have different types of procoagulant hemostatic pads. One of them is Chitosil from Abbott. Then we have the closure pad, T-Stat dry. Basically all of them act on the same concept, that there is some form of a procoagulant material which comes in contact with the blood and achieves quicker hemostasis as compared to manual compression. So when we compare Chitosil and closure pad versus manual compression, we've seen that time to hemostasis is significantly reduced, right? Major and minor bleeding rates are pretty much similar. Overall time to ambulation is also similar. Removal of the sheath at higher ACT levels enables early ambulation in the post-PCI period. But again, we've seen that the differences are not very significant, so that such that you use this in routinely all cases. The failure rates are also quite high, around 5 to 15-20% with the use of different devices. Compared with the manual compression, we've seen that the time to ambulation does not change such significantly that you need to use it in all cases. The complication rates are no different. Vascular complication rates may be somewhat lower. The good thing is that it improves the patient and the physician comfort. So again, the influence on hemostasis is small, does not significantly reduce the time to ambulation. Clinical utility of these devices is questionable. So the take-home message is that in most of the cases your gold standard is manual compression. If we compare mechanical compression devices with manual compression, again the clinical utility is doubtful. The only advantage that it offers is that it improves the operator comfort and does not require constant monitoring by the operator. For the patient, I don't believe it offers any major significant benefit. Again, with the hemostatic pads also, hemostasis is achieved somewhat earlier, but time to ambulation, vascular complications again do not reduce significantly. And that is why we have now had vascular closure devices which are active vascular closure devices. We have passive, amongst which we have passive approximators, and then we have the suture-based devices. So the passive approximators are basically the most commonly used Amongst these is the angioseel from Abbott or St. Jude, can be used from 5 French vascular access up till 8 French vascular access. The other examples of this are the vascular closure system, Minx, Exocele, Fish, right? So angioseel is basically a collagen based passive approximator. It basically seals your vascular access site of the femoral artery. Then we have gel based passive approximators like the Minx strip, and we have several different types, but most of them basically act on the same mechanism. That is, they are either collagen based, they are either gel based, and they basically close your arteriotomy site. How do you select the patient? We need to assess the femoral anatomy. Once you have taken a femoral puncture, you should assess the femoral anatomy either at the beginning or in the end, whether you want to actually go ahead with a vascular closure device. Precautions have to be taken if it's a very high excess, it's a low excess, there's significant PAOD, or there is a lot of calcification, or if it's a very small vessel, or if the patient is on GP2B3A inhibitors. So we can see most of the times we want our arterial puncture somewhere on the middle 1/3 of your femoral head, right? Always when you take a femoral artery puncture, it should be done under fluoroscopic guidance. Ideally, it should also use an ultrasound guidance if it is available. But if ultrasound guidance is not available, then definitely we should use fluoroscopic guidance. Once we have confirmed that, we should also confirm it with a femoral angiogram taken from the femoral sheath. We should look at the size of the femoral arteries, the location of the puncture site, if there is any significant calcification, if it's a very small vessel. After assessing all those things, particularly in 2 different views, the plain AP view and maybe the LAO or the RAO view, we decide if we want to go ahead with vascular closure with the help of angioseel device. I'll only be discussing the angioseel device because that is probably the most common passive approximator method used currently in our country. Consists of basically an anchor. There is a plug and a suture. It's used from 5 to 8 French access. Basically, it has an anchor, a plug and a suture, arteriotomy locator, and the guide wire. So we'll see this video in brief. So what we are basically doing is we introduce the guide wire through our arterial access site, and then basically we introduce the vascular closure device over the guide wire. The most important step over here is to confirm that we are in the artery. And how do you confirm that? So there is basically a locator in this system, and we should be able to see free flow of blood at this particular site. Just a trickle of blood isn't good enough. We need to see that there should be a free gush of blood to ensure that our device is actually in the intravascular location. So as we can see over here, there's a free flow of blood. Then you pull your system back, then you insert the system back again, and you see a free flow of blood. You confirm it once or twice that you are actually within the lumen, and once you confirm that you are actually in the intravascular portion, then you simply remove the guide wire and your introducer or the dilator system, right? So this is the most important step. Once we have done this, we take our collagen based closer, and we place the anchor in the device, and then we introduce the entire system, right? So we can see that at this point this is in the intravascular location, and now we basically lock the device, and then we basically set the anchor, right? We pull it again and we set the anchor, and again I'm basically showing the same thing again, that you introduce your sealant, and you set the anchor, you pull it back again, and then you basically pull the entire system. Now then we actually look, we pull the entire system until we can see a black colored portion at the distal end of the system. So we can once you pull this, we'll be able to see a small black colored line at the at the end of the suture. So once we see that, we know that our collagen based system has been deployed intravascularly, and at this point of time we take a scissor and then we cut this, right, and we keep the device on the side, and then we pull the suture back again. Pulling the suture again will basically ensure that the intravascular as well as the extravascular portion is sealed with the collagen based suture, and then we just cut the remaining portion of the suture. This achieves hemostasis. Patient is fit to get mobilized in a period of around 6 to 8 hours. So the components of this device get absorbed within 90 days. Repuncture can be taken after 90 days. There are no definite contraindications, just we need to assess the femoral artery anatomy and need to be more careful if the puncture is above the inguinal ligament or below the bifurcation of the femoral artery. In such cases, I would definitely say do not use a vascular closure device. Troubleshooting may be required in patients who have peripheral vascular disease, device not getting deployed or device fails, or if the anchor gets fractured or embolized, or if the collagen deposits in the artery or causes thrombosis at the puncture site, or collagen protrudes from the skin surface. But most of the times we've seen that the device works pretty well. We can use double wire technique also with the use of an angioseal, again not very commonly used but can be done for large bore excess more than 8 French. Comparing angioseal versus manual compression, we see device failure rate is very small, it's around 2 to 4%. Time to hemostasis is significantly shorter. Complication rates are also lower with the use of angioseal, particularly bleeding and hematoma. Again, I will not be discussing in detail regarding the other collagen or gel based closure devices, but just to remember their names, we have the MINCS, which is basically a balloon based device to place the sealant in the artery. Then we have the Exoseal from Cordis. Then we have the FISH, that's the femoral introducer sheath and hemostasis. Again, not very important to go into the details of all of these techniques. What we need to remember is just one of these devices which is commonly used, that is angioseal. Again, this is a duet vascular closure system. Time to hemostasis was significantly lower in the device group. Time to ambulation is also lower. Major complications are not significantly different between the two groups and can be used for diagnostic as well as interventional procedures. Then we have the Cardiva catalyst system, which is basically a nitinol wire and nitinol braided mesh disc. Can be used for 4 to 10 French arteriotomy sites. Again, just one of the other examples of passive approximation methods. For large bore methods, we have something known as the Manta device, which works similar to angioseal. It's a collagen based pullback device. Can be used for 12 to 25 French vascular excesses, available for in two sizes, 14 French and 18 French. And not going too much into the details of these techniques. So again, this is a Manta percutaneous vascular closure device studied in 263 patients, mostly for patients undergoing EVAR, TEVAR. We've seen success rates in excess of 95%, most of them requiring a single device, and major vascular complications seen in around 4.2% of the patients, and the mean sheath diameter was 22 French. Next, coming to the, I would say probably the most important method of vascular closure, that is perclose, can be used for excesses as small as 5 French to as large as 21 or 22 French. For large bore excesses, we'll need to use 2 devices. Basically, if you want to close more than an 8 French vascular excess. The other methods also, which is the star close method and the perclose, I'll be discussing in detail regarding the perclose method, because this is probably the most important of the vascular closure devices. Basically, how to use this, you have your sheath, you have your wire, you flush the system, you introduce your 035 wire through the sheath. After the index procedure, again you check the femoral artery anatomy if this can be done. If it's a very high puncture, low puncture, extensive calcification, PEOD, don't do this. If otherwise everything is fine, your puncture is fine, you introduce your wire, you introduce your system, advance the device till you see the wire exit port is at the level of the skin. You remove your wire, you introduce the entire system at an angle of 45 degrees until you see a gush of blood coming from the side where we already flushed, right? It should be an arterial blood. Then there are 4 important steps. The first step, it's already been labeled on the system. The first step is to lift the lever, right? Once you've lifted the lever, you pull the entire system so that it comes in contact with the wall of the artery, again at an angle of 45 degrees. And then you basically depress the plunger and it basically deploys your needles, right? Then with the help of your thumb and fingers, you pull the plunger back, then you slightly push the entire system, and the step 4 is basically you cut them with the help of needles, right? And next is lower the lever after you have slightly pushed this, and then you remove the entire system, right? When you remove the entire system, you basically will have before you remove the entire system, you introduce the guide wire such that if the system fails, you can use another pro glide, or maybe you can do some other technique. So you have a white tipped rail, and then you have a blue tipped suture, a blue colored suture and a white colored suture, right? Pull the blue colored suture, keep the white ended suture on the side. You remove this system, you already have your wire in place. Then you basically take the suture trimmer, right? Now is the time to tie the knots, right? It can be used to advance the knot. You advance it, and then with the help of a one hand technique, pull the suture with the index finger, and with your thumb you apply constant increasing tension, right? At this point you remove your guide wire. Apply this pressure for some time till hemostasis is achieved. Once you see that there is no further bleeding, then you can actually remove this system, right? Again, the white tipped suture is something which you are able to see on the sides. There is nothing to do with the white tipped suture at this point of time. Now you remove the suture trimmer, and now is the time to just trim the suture limbs. Take both of these sutures, pull the lever on the trimmer. You'll see a small hole in the tip of the suture trimmer. Place both the sutures inside it and introduce it with increasing levels of tension. You apply it for some time, you ensure that there is no hemostasis, and then with the help of the black lever you just cut it. Your vascular closure is done. One of the most difficult methods of achieving vascular access, vascular closure, but probably one of the most effective and one of the most safe methods also. So again, Perclose is a suture based technique. I already demonstrated the steps for the same. We've seen that patient satisfaction is very good with Angioseal and also with ProGlide. Probably Angioseal is patient satisfaction is even better because it does not cause too much pain to the patient. With the use of ProGlide, there is some pain. Major vascular complications do not differ between the two groups for small excesses, but definitely if you are using a large excess, then we need to use these devices. In multiple studies have been done, most of these studies show that although the major vascular complications are no different between the two groups, patient satisfaction is good, time to ambulation is early, and definitely for large bore excesses, this is a very useful method. So the most currently used methods which we use are the ProGlide and the Angioseal. We also have the Manta device and the Minx device. So ProGlide and ProGlide is basically a suture based technique, and if we want to use ProGlide for large bore access, we need to use two different ProGlides, and also it is very important to remember that we need to apply them before we do the procedure. So once we have taken the access, we place two ProGlides, we keep the two sutures on the sides, and once we finish the procedure, then is the time to tie the knots one by one, right? So two ProGlides cannot be done at the end of the procedure. The two ProGlides need to be done at the beginning of the procedure. Angioseal again can be used for 6 to 8 French vascular access. Placement is extraluminal for ProGlide, it's intraluminal plus extraluminal for the Angioseal. So again, for a large bore access, we have the ProGlide and we have the Manta device. Most commonly we use the ProGlide device. We use two ProGlides when you want to close anything more than 8 French vascular access. Very useful for total percutaneous procedures like TEVAR as well as transcatheter aortic valve replacement. A small word on transradial sheaths and sheathless catheter platforms. Standard sheath size for radial are 6 to 7 French. We have slender sheaths, we have glide sheaths, so 6 to 7 French. We have something also known as a TR band to close the radial artery access sites, where basically we slightly remove the sheath, we clean the local site with the help of spirit gauze which is dipped in spirit. Then we apply the TR band such that the green dot is just over the arterial access site, right? You see the green marker over the arterial access site. We just basically close the TR band and we inflate it with around 10 to 15 ml of air. We see that there's no further bleeding, and then we can actually go on to remove the radial sheath. So we take, we just confirm that the green marker is at the level of the arterial entry site, and we take a special syringe which comes along with this. We inflate it around 10 to 15 ml of air, and then we just remove the sheath. This is done. We slowly reduce the pressure every 15 minutes to 30 minutes, beginning 1 to 2 hours post procedure, and at the end of 3 or 4 hours, the patient is usually fit to go home if it's a diagnostic intervention. So the take-home message is that vascular closure devices are very useful for large bore vascular access and should be used whenever you are doing TAVI or TEVAR. Although the rates of vascular complications and bleeding are not different when you use it for small bore accesses, it significantly enhances the patient comfort. But we do not advocate the routine use of these devices for routine angioplasties which use a 6 or 7 French vascular access. I think they should mostly be reserved for large bore accesses. And very important to learn these devices because they also have a learning curve, especially the per-close device, because a lot of failure it also happens initially when you are learning this. I think it's very important to know about these vascular closure devices. Thank you.